Hello, good morning or afternoon, depending on where you are. Welcome to Flexpa's Payer-to-Payer Exchange webinar. We're really excited to share some of the work that we've been doing on payer-to-payer exchange here, and also to create a little bit of an open forum to learn from each other, to discuss the opportunity that we really see beyond compliance. Payer-to-payer exchange is part of the compliance and interop conversation today, but there are really direct benefits to doing it, and we think that we can shift the conversation a little bit towards a little bit more towards the real direct benefit and opportunity that's created by thinking about how this will change healthcare and how it will change uh, the information that follows a patient throughout their healthcare journey. 21 days is the average amount of time that it takes a payer to complete a chart chase. So a new member enrolls in a health plan today, and on average, 21 days later, that payer has some kind of an idea of that patient's medical history, of their claims history. And that today is really powered by administrative process. So it's powered by real humans getting on the phone, sending faxes, and assembling a chart manually. So what is payer-to-payer exchange and how might it change that 21-day chart chase? Well, it's pretty straightforward, we think. It's the process of electronically transferring patient health information from a previous payer to a new payer. And the idea here is that as a patient goes through their life, their claims history, their prior authorizations can follow them. So that's really what the idea is here. And the point of doing that, which we'll get into in a moment, is continuity of care at the end of the day. So that when I switch employers, for example, and therefore switch health plans, that my new payer, my new health insurance, knows exactly what I've been authorized for already. Compliance. How many times have you been pitched a compliance solution? So far, interop efforts like CMS 9115 and the upcoming CMS 0057 mandate have really framed payer responsibilities as a matter of compliance. We have a bunch of checkboxes. We have to deliver a FHIR API. We have to deliver a Smart on FHIR OAuth component of that. We have to deliver backend services, design ETLs. All of those things are really framed as, and the solutions for those things are framed as compliance checkboxes. We're checking the box. But there's an opportunity beyond that. And we totally get that compliance can be a huge burden. All of these mandated APIs have operational and implementation costs. And we think there's a perception that we just need to check that box. We need to spend as little as possible. We don't see the direct value. Sometimes we're not even sure if anyone out there, maybe other than Flexpa, is actually using these APIs. Payer-to-payer is different. It's different in a few ways that I want to highlight. One is that payers can use it. That's a big difference. Unlike other APIs where payers are just producers of the API and have all of the costs of production associated with it, payer-to-payer is an API that and means of data transfer that the payers can also act as consumers of. Payers can act as not just as responders to data requests, but also as originators of those requests for the first time. And because of that, it actually has an opportunity to provide real value to payers. In standardized formats, which is a really key point here, existing electronic exchange suffers a lot from a lack of standardization. So payer-to-payer is different. And on that first point, if you want to think about the responder to requester kind of axis there, provider access, patient access, the prior authorization API, the provider directory API, all of those are really shifted towards the payer having a role as a data responder. So these APIs are, and the mandate creates a responsibility for payers to act as a responder to other parties. But payer-to-payer exchange has a new role, and that's the role of the requester. So it's all the way over here on the right, and that is an opportunity. Let's talk just really broadly about the use cases and benefits before we get into any nitty-gritty details about APIs and data formats and all of that. Why are we doing this? What benefit can we actually gain here, and what is the opportunity? And we think that really breaks down into three key use cases. So the first is to just end the chart chase. So instead of having a chart chase, we can reduce that down from an average of 21 days or 90 days in some extreme cases to just 0 days. So at the date of enrollment, let's go request this data. When coverage starts, have all of that health history lined up, have the prior authorizations from the past payer on day 0. So end the chart chase for good. And that really has other consequences. It has other consequences for star rating, for example. The second is transition and continuity of care. There's a really direct patient benefit to having their claims history follow them when health plans change. So transition and continuity of care, that's a really specific human direct benefit. And lastly, operational cost reduction, risk adjustment, much easier when we have all of this data on day 0. That chart chase process can realize a cost reduction if we're doing it on day 0 and not on day 21, and if it's powered by electronic exchange. So that's how we see the world, and we really want to share that vision because we think these use cases are really strong and they're different from the use cases for past APIs and past compliance mandates for interoperability. Before we get into exactly how all this works, where things are going, we want to show you the future. So we want to show you what it would really look like to ask a patient for prior insurance information and to go get that in real time during a digital enrollment process. So I'm going to pass things over to Kyle, my colleague, and he's going to show you a demo of the future.
Right. So what I have here is just a small application that I put together. Let me actually turn my video on too. Small application that I put together to give us an idea of what this could look like. So we have Blue Health Insurance, and a member has come, and it's time for them to do their enrollment. So as a first step in the enrollment, the member might come in and give some basic demographic information. This is going to be just generally identifying information that is needed to be collected anyway. It might include some social security numbers, and then we move on. Now, the second step in this enrollment can be something where we do a health history import. And this is what is powered by payer to payer. We can go and collect information. And so we say, as a member, yeah, I'd like to link my previous coverage. And my previous coverage was with Humana. And so then the question is, what was your member ID? So the user, the member, can say, oh, I had a member ID, and it was something like this. And then they can click connect. And what this is actually doing is this is actually going out, connecting to an API that is managed by Humana and pulling some information down. And what we can see here is that we have recorded a consent, and this is a FHIR consent resource from FAST. We've recorded a consent. We've retrieved records from Humana for a specific member with a coverage period here. But importantly, on day 1, we see, or day zero, we see that there were prior authorizations that were found in this payer-to-payer exchange. And so we can immediately flag this and let our care teams know, let our care coordination teams know um, that this is something that we need to work on and we need to have figured out before there's any interruption in critical services. And then additionally, just to show a little bit here, we have this is all of the health record here. Um, we have an entire bundle of health data, all based in FHIR. Um, and so what we have here is we have all of the previous claim and health record information on day zero before the enrollment is even done. And so fun little thing there. So we end up with a lot of information. We end up with no chart chase, and some of our most important continuity of care is taken care of and identified up front. So yeah, that was the demo.
Thanks for that, Kyle. There's a couple of key metrics about pair-to-pair exchange, and just to set the scale of this problem in context here. There's 20 to 30 million new enrollments a year. 10 to 15% of Americans change coverage every year. If there was a standardized electronic exchange of this data, in practice, over 90% of those patients could have their data follow them electronically from a past payer. Back of the envelope math here, there's probably a $900 million direct industry cost currently just on the chart trace record acquisition. So that's direct cost. It doesn't reflect the potential loss of the opportunity cost there, right? So of a miss on a star rating, for example, because of consequences of data not being available on day zero. So those are some really valuable scale and impact setting metrics, just to give a sense of how big this opportunity really is. So we've shown you a little bit about why we think we should all start to think about pair-to-pair exchange as a direct opportunity and not as a check the box on the compliance list problem. And we've shown you what that future could look like. We've shown you that we can design electronic enrollment processes where data follows patients. Well, how does this all happen? How does this come to life? And it comes to life through CMS 0057. So at a high level, CMS 0057, as many of you are familiar with already, it covers more than just the payer-to-payer API. This is a slide from the CMS deck on 0057. It introduces provisions on prior authorization, on a provider access API. We're going to laser in, though, of course, on the payer-to-payer portion of it. So at a high level, the purpose of payer-to-payer in the text of 0057 itself outlines that facilitating patient data exchange at the start of coverage and with concurrent payers will benefit transition and continuity of care. High-level requirements that many of you, I'm sure, are familiar with already. There's a go-live date of January 1st, 2027. It includes claims, encounter data, and prior authorizations. It's an opt-in patient consent process. So patients must be given and displayed an opt-in request to transfer this data, just like you saw in that futuristic demo. It applies to the same group of payers as 9115 did. So it applies to Medicare Advantage payers, Medicaid, CHIP, QHPs on federally facilitated exchanges. There's a little bit of nuance to this next point, which we're going to dig into. Generally, the request has to be made within 1 week of coverage. There's a big asterisk there that we'll unpack. And it covers up to 5 years of previous data. So payers have a dual responsibility in 0057, of course, to be the responder to these requests. So from a compliance perspective, that's a check the box scenario. But on the flip, they also can take advantage of this and have the opportunity of electronically exchanging and retrieving data for new enrollees, um, and take advantage of each of these 6 benefits. Let's dig in a little bit into some of the specifics here, because there have been decks and blog posts and LinkedIn posts that cover the requirements. But if you actually dig into 0057, there are a few elements of it that have actually caused a little bit of confusion that we want to help clarify. And I really want to encourage anyone, if you have questions at any point here on the details, please ask, and we'll take questions. We'll take questions live and at the end, but please jump in if there's something here you want to dig into. So on the data content requirements, of course, payer-to-payer in CMS 0057 will include claims and encounter data. There is an exception to some of the elements in the claims data, and we'll cover that in a moment. It also includes, just as CMS 9115 did for the patient access API, all data classes and data elements inside of US CDI that a payer is in possession of. And then critically, it also includes certain information about prior authorizations that the past payer maintained with a date of service after January 1st, 2016. So that's a little bit more detail there on just exactly what data is required. This is the part of 0057 that covers that period requirement. In the initial proposal, January 1st, 2016 was a line in the sand date that was fixed. So any data after January 1st, 2016 was going to be included as a requirement of this API. But in the final rule, it actually specifies a rolling period of the previous 5 years. So the previous 5 years worth of data is what we can expect as requesters of this data. And that's obviously rolling. On US CDI specifically, and this was true of the patient access API as well, there isn't an expectation that payers store and maintain and make available and convert unstructured clinical data here without any exceptions. That's actually not required. But to the extent that a payer is engaged in and has data systems and processing systems that are already representing US CDI data, clinical data, they have to make that available. So there's not an extra requirement here on parsing and converting unstructured clinical data into structured data. But insofar as that's already happening in the industry and insofar as those systems already exist, we do have to make that available. There's an exception on the claims data that I highlighted just a few moments ago on remittances and cost sharing. Those are excluded. So claims data does not need to include provider remittances or any patient cost sharing information. CMS proposed that initially and also received responses that validated that belief that they're often considered proprietary by payers, for one, and they're also sharing that data without those cost details would still complement the existing clinical data. So we're not required, nor as requesters, as responders, we're not required to fulfill those lines. And as requesters, we won't be able to expect them to be there. Of course, they are there in the patient access API. And so if there's a use case there that's well fit, the patient access API does provide a mechanism to collect that data. I do see a few comments in the chat. Kyle, anything that we should pause here and address?
Yeah, so I think one of the questions that came up here was the very first one. How is data incorporated into the payer systems after a request is made?
How is
And
data incorporated into the payer systems after a request is made? So as a requester.
Yep.
So typically, well, this will be FHIR formatted data. So in a typical system, the payer will already be maintaining a FHIR data repository because the payer has other compliance responsibilities to produce APIs, right? So the payer is already producing a provider directory API. They're already producing a patient access API. And those components require them to already have made available in their system a FHIR service. So typically, what we would do is design a ingestion pipe, so to speak. We would pipe the responses from the past payer into that same FHIR data repository. Part of the implementation guides that are referenced in CMS 0057 and that are expected to be the standard that everyone follows include backend services, FHIR backend services as a connection mechanism. So we expect that really there's actually two paths. There's a single member match and a bulk member match. In the case of the bulk member match, where we're doing many members at once, we're going to receive a new line delimited file, and we're going to parse that on an individual line basis. I see as well, there's a little bit of a thread here. Is there a framework for testing connections with other payers? Grace chimed in there that that's still sort of in the works, and there's certainly a TEFCA impact here. Kyle mentions that there is no explicit testing framework right now, but he points out that the Connectathon, HL7 Connectathons have been in practice the only place in the real world where that's happened. So Flexpa has been a part of that in the last Connectathon cycle and will continue to be in the future. From Vishnu, we have a question. What level of encounter data is included? Was encounter data ever made available via the patient access API? So it is made available via the patient access API. And the extent of it is all data classes and elements in US CDI. The limitation of it is the limitation of only data that the payer is in possession of. So only data that the payer has already, as part of its processes and as part of its system design, already transformed into a structured format. So for example, during the processing of a prior authorization, if we have a part of our system that is taking that data and structuring it into US CDI, we do have to make that data available in the patient access API today. And we also need to make it available in the payer-to-payer API, as well as the provider access API, which we're not talking about today, but is another part of CMS 0057. Another question from Tom. How do we expect authentication to be mediated between payers at the per payer app layer? Fantastic question, and we're going to get to that in just a moment. So a couple other elements here, past prior authorizations. In CMS 0057, this section actually references the prior authorization API. So to get a full understanding of the requirements there, you do need to read the prior authorization API section. But the idea here is that if payers were to exchange information about prior authorizations that they have done, that new payers could use that information to determine if the patient needs a new prior auth and whether or not we have sufficient data there just to issue a decision right away. So that can eliminate another doctor visit. It can eliminate additional administrative work. So that's kind of the point of this. And the payer-to-payer exchange includes roughly this list. So the summary here is the status of the prior authorization, the date it was approved, the date or circumstance for an ending, items and services approved, related administrative and clinical documentation. There are two really important details of this that I just wanted to highlight. One of them is that there is an exception in 0057. Denials are accepted. So denials do not have to be included here. This only mandates the inclusion of approved authorizations, approved prior authorizations. And that makes sense if you understand that the purpose of this is to facilitate a rapid reapproval by a subsequent payer. And we'll get to the other exception or detail here in just a second, which is unstructured documentation and forms. So one of the comments that CMS received in response to the proposed version of the rule was that including unstructured documentation and forms is a burden, and sharing that documentation would be burdensome. CMS modified the patient access and provider access APIs to remove that requirement. So for the patient access API and provider access API, it's not a requirement to make available unstructured PDFs or copies of faxes. But they said that unlike, and the conclusion was that, well, the burden there just outweighs the benefit. But they did say that unlike those two APIs, the burden does not outweigh the benefit in the case of payer-to-payer. So one of the goals of payer-to-payer just explicitly being promotion of continuity of care, that really does require us to be exchanging all of the documentation and forms that were part of a prior authorization request. So the prior authorization data set is expected from a requester point of view here, is expected to include the documents that are going to help you facilitate a faster decision. I found this really interesting too. There's been a lot of commentary about exactly when a new payer has to make this request. What are the timelines? What are the requirements there? And it seems to suggest, in some parts of CMS 0057, it seems to clarify that 1 week after the start of coverage is the window. But that's not actually what's in the text. So in the final rule, we see this element here that suggests we emphasize that payers must begin the process of collecting the previous information and a patient opt-in no later than 1 week after the start of coverage, but it might not be completed then. And that's totally understandable. We have a responsibility to initiate that process within 1 week, but it may take a patient some additional time to respond, and that's expected. Payers are encouraged and expected to make some reasonable effort here to gather the permission. So that might mean a follow-up email or a letter in the mail. And so there's a little bit of flexibility there in terms of when we actually need to make this request to the past payer. And that's expanded in this section. CMS wrote, we are finalizing a modification to clearly establish that the 1 week time frame for requesting patient data begins once the impacted payer has sufficient identifying information. and the patient has opted in. So that 1 week clock, that 7-day period, that starts only once sufficient identifying information has been collected. So that doesn't mean that we only have 1 week from the start of coverage to get this done. We do actually have a longer period of time. The 1 week referenced here is actually different from the 1 week referenced in the previous slide. So these are two 1 week periods. First, we must initiate the process with the patient, with the member, within 1 week of the start of coverage. And two, once that process has finished, we have 1 week to actually go and request the data. And of course, payer-to-payer in CMS 0057, as many of you know, is an opt-in approach. Exactly how that works, we're going to dig into here. But this is an opt-in process. We do need to educate members about what they are granting permission for us to do. And it does require an affirmative act. So let's go back to that January 1st, 2027 requirement. That's still 21 months away. We got plenty of time, right? Well, one of the pieces that has not been commented on, was not commented on by any of the commenters to the proposed rule, is that currently enrolled patients are included in this effort. So in the proposed rule, CMS said that they proposed that impacted payers must establish and maintain a process to gather permission and identify previous and concurrent payers from all patients who are currently enrolled. And they suggested that maybe that should start earlier in 2026. Because they received no comments, they decided to align it. What that means is that as of January 1st, 2027, we as a group of vendors and payers need to have that process established. So for all Medicare Advantage members, we need to be ready on day one, on January 1st, 2027. We have to have that process in place to request, to gather permission, and to offer patients the opt-in ability. So that impacts millions of Americans, right? That's not a lift that it is going to start on January 1st. That's a lift that we really believe has to start now. So what are the gaps and challenges here? I'm sorry for some walls of text there, but hopefully that was informative. What are the gaps? What are the challenges that we see here? We really think they break down in two ways. So the first is consent and this opt-in process. What do we need to do? What is required? What is allowed? What's not allowed? How does it work? Consent. So how do we establish and collect opt-in consent from a member, from a patient for this process? In 0057, CMS is explicit about leaving the actual implementation process up to payers. So the feasibility of any particular opt-in process, that is a decision that is left to payers. They also explained here a little more detail there that, again, each payer is responsible for developing and maintaining that process. There was a commenter who suggested that that requested guidance rather on how to collect that permission. Would it be appropriate? How would we deal with a member, for example, who cannot use a patient portal? And CMS clarified that because each new payer is individually responsible for designing this permission process and requesting it, if a payer believes that a patient portal or a smartphone with the appropriate protections is appropriate to gather, they're certainly permitted to do that. but CMS is not prescriptive about that process. So there's no prescription about what is or what isn't required here. Certainly, and I think with a mind to efficiency, promotion of an electronic means of doing this is certainly a good idea. But also, it's a good idea to be able, and an important idea, to be able to request that permission in other ways and to be able to submit it in other ways as a fallback. So here they explain for patients who require assistance, a personal representative would be allowed to assist, for example. What this means, though, is that the opt-in consent process is a blank page. There is no clear roadmap for exactly what we have to build. And that is burdensome. And that applies to the initial opt-in process. It applies to needing fallbacks and processes for non-electronic opt-in. It applies to revocation, and it applies to all of the issues that consent management already has. The second gap is network. So how do we establish connectivity to APIs from hundreds of other payers? And trust me when I say that Flexpa knows this pain. CMS highlights that, and they received a comment that this will take time to establish the necessary links, to establish data use agreements, to establish security protocols. That will take longer, much longer than 1 week if a payer decides to be completely reactive here. So it would, in effect, be impossible to expect a payer to connect in an on-demand way after January 1st. And CMS acknowledges that. And part of the acknowledgement of that, and in delaying the compliance date from the proposed 2026 initially, was to provide additional time to build the requisite API technology and to coordinate with other payers to establish those linkages. They encourage payers to establish data use agreements and register with each other's APIs prior to compliance dates. And I think the subtext here is also that there's time built in for TEFCA as a governance framework to evolve a little bit to help us deal with this challenge. Establishing hundreds of API connections is a huge ask. It's very difficult. It's difficult from an administrative perspective, from a technology perspective, from a governance perspective. There's a missing directory. Very foundationally, we need a directory of endpoints. QHIN to QHIN. If we are going to rely on TEFCA, we need QHIN to QHIN exchange to be live and in production. It's testing right now. We need that to continue to evolve. We need time for it to evolve to catch up to these needs, and we need it to exist by January 1st, 2027. Otherwise, we'll be limited to requests inside of a given QHIN. The good news is that Flexpa is here to help. Well, who are we? Why would you want our help? How can we help? Flexpa has been a leader on patient consent and payer API networks. So we do a digital-first patient consented access to claims data. That's what we do. Patient consented access to claims data. And we've built that consent and that process, that opt-in patient process, into our product and into our company since day one. Consent is what we do. And we built the largest payer FHIR network in production. So we have connectivity to 330 health plans on top of their patient access APIs. We've talked to all of the teams. We've established all of the relationships. We know all of the details about the less clear or less good parts of your APIs, and we also know for the leaders what makes your APIs so great. And we've built support for all of the relevant technical standards like Karen BB, DaVinci PDEX, where we've been a public HL7 Connectathon participant in the tracks, and smart backend services. So Flexpa has been positioned on both consent and network to be very helpful. We've got the largest payer FHIR network. We connect to over 330 plans, as I said. We've got coverage for almost 160 million CMS covered lives. We released an industry-leading payer endpoint directory. So we have a public, comprehensive list of all payer patient access API endpoints. We've published biannual state of the payer network reports. So we've published industry-leading reviews of the quality of this network, of the quality of the APIs, about conformance to 9115, and gaps to remain to be closed in the future. And so what I want to highlight here is that in a real way, Flexpa has known the pain of building opt-in consent processes and of establishing connectivity across a national network of FHIR endpoints built by payers. Those are the same two gaps that exist today in CMS 0057, and we can help. We do have a limited space cohort of payers that we're working with already. We're going to expand it a little bit in the summer here. So your participation is welcome. We want to be partners. We want to close these gaps. We want to be bridge builders between the islands of different vendors who are selling compliance solutions, between the patients who really just want to use their health insurance, and between the payer interoperability teams who know the pain of actually delivering these APIs. There's lots to do. Testing and validating consent flows. We have to establish a mechanism in advance of 21 months from now. We have to establish it before January 1st, 2027, that allows a consent and an opt-in process to be given to all current enrollees. That's going to be a big lift. And we're here to help. We've got front row seats. We're participants in the fast consent management community meetings. We're going to increase our participation there. We've participated in all of the DaVinci HL7 Connectathon tracks for PDEX. And we have all of this wealth of lessons that we've learned from CMS 9115. So it's an open offer to join our existing payer cohort in being the first to end the chart chase for good. And so, again, closing message here, we are excited to work with the payer community, with other vendors, to figure out how to solve some of these gaps, to explore different approaches to closing them. And as a closing message, the reason that we're doing this all together is not just to check a compliance checkbox. There's a real opportunity here to improve the transition and continuity of care, to deliver real operational efficiency gains, and to prove that interoperability is not just a cost center, that it can drive real transformation, both in the lives of real people and patients and members, but also in the business of health insurance. So we'll conclude there, and happy to take any additional questions from the chat, or if you'd like to grab the mic, happy to facilitate that too. Kyle, do we have anything that we should address right away?
Yeah, I think Grace had a great question here. She was asking, she said, so Flexpa is going to provide a place with all the payer endpoints for payer to payer. That would be awesome. What's the catch?
Well, the catch is that we need your participation to do it. So one of the benefits that we have, having built a network on top of CMS 9115, the patient access API, is that we've established both administrative and relationships with every individual payer, but also a technical connection. Now, the connection will be different for 0057. And And certainly the consent flow will be different. It won't require OAuth, for example. But the catch is that we need to build it together. So we can only act as a vendor. We can only act as an enabler, as a validator, as a guide. But payers have to be real participants. So hopefully that sheds some light. Any other questions in the chat or threads that we had during the talk there, Kyle?
The only other one that came up was Tom was asking about how we expect authentication to be mediated between payers
Oh,
at a
right.
per payer app layer. And I shared in the chat that one of the important things that the PDEX IG sets out is that there's the public cryptographic signatures. So it sets up a future directory where each pair sets up their public cryptographic signatures so that when they make an authentication request that is signed, then that can be validated to ensure that the pair is who they say they are. So a little bit more into the details of how this works, but just want to make sure that I answered the question.
No, that was useful. Moving away from OAuth, though, I think was sort of the key that I was
Yeah.
trying to get my head around.
Yeah, this is a part of the gap on the consent piece of this is how do we, not just the collection of it, but the representation of that information and the subsequent patient matching operation on the back end by the past payer. So we don't have to do an OAuth patient facing piece here, but we do use a backend services, smart backend services, server to server authorization, and then exchanging enough demographic information, enough information about an individual in order to successfully get a match. That's part of the gap.
That we're comfortable with then sharing, like as a payer, that they're comfortable sharing this data with the next quote unquote payer and not a malicious actor.
Yeah, and so to deal with that problem, we need two things. We need the backend services connection where we're exchanging keys. So we're using UDAP, for example, to register with each other, right? And to know that the other party is trustworthy and that we can identify them, and also that their requests to us are authenticated as well. Part of the gap there is on the directory level. So unless we have a directory of payers who
Yep.
are trusted participants, how do we establish who to trust? Because the
Security is
technical
critical.
solution there doesn't, the technology doesn't provide an answer. That really is at some level a governance question. And certainly looking to TEFCA as an endpoint directory, I think is a natural inclination, but that will also require all payers to become QHIN participants, which optimistically will happen, but is a big ask.
Right. Yeah, that's interesting. That web of trust problem is central to my mind in thinking about how to provide those APIs to facilitate that kind of connectivity.
Yeah, exactly. And otherwise, otherwise, they're just at the end of the day, there has to be a list. UDAP does provide a mechanism for delivering a. I'm gonna mess up the specific term that's used in UDAP, but essentially for delivering a signed certificate that says from a third party, from a governance layer, for example, that the entity that's making this request is has a certain certification or is a known entity with a specific identifier. So there is a technical mechanism where we could rely upon a third party to verify the identity of a given system, but that will require establishing it as a component of a governance layer.
Thank you.
There's also I believe this is part of FAST, the FAST working group. There is an effort to establish a national directory IG as well. Any other closing
Josh,
questions or comments? Yep.
yeah, I was going to say, Nicole Coleman here had a question about how the consent module would work. Would you interface with the plan's member portal? If a member consents on the enrollment form, do we notify you some kind of way, or do they go to the Flexpa app?
So in a lot of ways, that's a we have to figure it out question. The vision for the future that we have is that this opt-in process should be exposed to a patient at the same time that they're doing other enrollment activities. So that doesn't have to be electronic. It's great if it is, but it doesn't have to be. So if you have a digital member engagement process, enrollment process, we really see collecting the consent as being an integrated component, like it was in that demo of that process. And there's really only two big areas of data that you need. You need demographic identifiers, but you're collecting that through the enrollment process already. So that's not new. You do need to request from an individual patient enough identifying information about their past payer to actually know who to go to get that data, and to do a member match. And that's not a trivial problem. I'm sure even people in the industry, I think if you ask them to explain Blue Cross, they'd probably not give a totally correct answer, right? So when it comes down to individual members understanding and associating a brand with an organization, with an underlying health plan, that's a confusing thing that Flexpa has a lot of experience with, because today, when someone uses our patient access flow, we have to ask them that same question: what's your health plan? And understanding how to map that effectively from a brand that they have in their head or a logo that appears on a health card, understanding how to map that from that perception to a specific entity, and then ultimately to a specific endpoint, a specific FHIR endpoint. That's kind of underneath the hood of all of this. And that's what we have a lot of experience doing. So we don't think that there's we don't have a vision here for a consumer-facing Flexpa experience. We really want to enable the bridges to exist underneath it so that you can introduce this opt-in during and inside of existing digital systems, existing digital member engagement systems, and not introduce some new thing, but to expand and to build upon the processes that you already have. And don't forget, there also have to be alternative pathways. So maybe that's a call center pathway. Maybe it's a physical mail pathway, right? There have to be sort of other on-ramps for patients to provide their opt-in. Hopefully that answers the question.
Yeah, Josh, I thought one last piece here, as we're bumping up on time, I thought it might be good for us to kind of reiterate our call to action. Like what we're doing here, we're not saying like, hey, we've got something we want to sell right now, but instead we're looking to work together, to test together, to deploy together, and to figure out what this looks like as we build it out. So can you reiterate that a little bit for me?
So to get from where we are right now to this vision of the future, to deliver transition and continuity of care and operational cost reduction and all of the benefits that come from those things, we have to solve certainly the consent management piece of this, the opt-in process, and we also have to solve the network. By its very nature, those are not things that exist out of box today. Those are actual innovations and problems that we have to solve together. Where we see our role here is being in, first of all, an active participant, a collaborator, and creating a forum to help answer these questions together. So there's pathways here for participation with us where it's in the open, it's public. maybe it's at the Fast Consent community meeting, maybe it's at a Connectathon. We're participating in that way, and that's openly available to any other public participant. And alongside that, there's an opportunity to test and validate some of these flows together in specific enrollment processes, and for us to help guide connectivity for you before, certainly before January 1st, 2027, but also right now, because we're going to have to figure out how to deliver this opt-in to all of our current enrollees. And that really requires that planning process to start. So the way that we see this rolling out ultimately is collaboratively through partnerships, both publicly in the interoperability community as a public participant, and also as part of our direct relationship cohort. And so if that's interesting to you, we'd love to talk more. I've got my email up on the screen there at josh@flexpa.com. I'm also very easily accessible on forums like LinkedIn or Fire Chat. I'm kind of all over the place. And the next in-person interop event I'll be at will be Fire Dev Days. We'll be giving a talk on patient consent there. So if that's on your calendar, would love to connect in person as well. But I think there's a really big opportunity to start to think about how we're going to collect and establish consent, how we're going to introduce this process into our existing enrollment, and how we're going to benefit from that at the end of the day, so that instead of this being a line item that is just a compliance cost, we can help you shift the thinking internally towards the opportunity, because that's going to be the mechanism that you can use to expand the resources that are dedicated to interoperability, to expand the resources that are dedicated to your teams and the projects that you're leading. We can help you communicate that message in any way, we're here. We're going to make this webinar publicly available, so we'll send it to everyone as a follow-up. Well, without any other interjections, Kyle, I'll take that as a last closing cue.
Yeah, for sure.
Well, again, we really appreciate participation today. Great questions. We'll review some of the chat for if we missed anything and follow up. Thanks again for coming, and we hope to see you more in the future. Take care.